Hi, my name is Dina Cirillo. I'm an MSN to DMP student at the University of St. Augustine, and I'm presenting my evidence-based practice project of the effects on aromatherapy on post-operative nausea and vomiting. I chose this topic because I was a recovery room nurse for 10 years, and this was a problem I dealt with quite often. So let's start with an overview. First, I'm going to define my practice problem. I'm going to identify my PICO question. I'm going to translate the evidence that I appraised. I'm going to classify the evaluation methods. I'm going to justify the change model that I chose to implement the project. I'm going to elaborate on dissemination of my practice project. And then during the conclusion, I'll give a summative review. So the problem I identified was post-operative nausea and vomiting. It's a common adverse reaction to general anesthesia that increases a patient's level of pain and suffering during the recovery phase. This problem affects 75 million people annually. 80% of patients are deemed high risk to this complication, and it can last anywhere from 24 to 48 hours after surgery. Complications include electrolyte imbalances, dehydration, wound dehiscences, increased intracranial pressure, delayed discharge, and then unanticipated hospital admissions. All of these complications increase healthcare costs for the patient and the facility. The standard of care, which is antiemetic administration, often leads to more adverse effects. So my PICO question is, in post-operative patients, what is the effect of aromatherapy compared to the standard of care, which is antiemetic therapy, on decreasing nausea and vomiting after receiving general anesthesia during phase 1 and 2 of the recovery period? Let's discuss the literature review. I used several key terms to find relevant articles on my topic. I used post-operative nausea and vomiting. I used PONV, which is the abbreviation for post-operative nausea and vomiting. I used aromatherapy as well as essential oils. I searched databases of PubMed, Sinhal, as well as EBSCOhost. The inclusion criteria was peer-reviewed, full-text, English-only articles from 2014 to 2019 that included adult population after surgery. I just really pinpointed use of aromatherapy on post-operative nausea and vomiting that took place in the PACU or acute care units, and I was interested in any fragrance, not just one fragrance. I was open to all fragrances used for aromatherapy. Exclusion criteria, I excluded any articles that related to pediatric surgery, any articles that were involved with combination alternative therapy methods, which include things like acupuncture, music therapy, and aromatherapy as well. I excluded articles that were in an outpatient setting, and then articles that just were focused on post-day nausea and vomiting after surgery. So my initial findings, I found 52 articles, removed the duplications, it whittled down to 43. I did a title review and a little bit of an abstract review, which used my inclusion and exclusion criteria to eliminate the articles down to 9. Within those 9 articles, I did further exclude 2, which were more focused on the outpatient setting and post-day nausea and vomiting, which I didn't realize that until I read the full articles. So they were also excluded. So my search included 7 articles that were quantitative. So I used the Prisma method, and I did document Moher on the screen for the method that I used for my searching. The level of evidence in this literature review were determined using the strength of recommendation taxonomy, the SORT model. So according to Ebel et al., the SORT model addresses the quality, consistency, and quantity of each individual article. After the evidence was leveled, I completed a detailed critical analysis. And what I got from my critical analysis is that ginger, lavender, and peppermint are effective to treat postoperative nausea and vomiting. Throughout any of the studies, no one reported adverse reactions to aromatherapy. Of course, the participants were screened for allergies prior to implementation of any aromatherapy. A multimodal approach is recommended, and this includes things like fluid intervention, as well as antiemetic standard of care, and aromatherapy. So aromatherapy is found to be a holistic adjunctive therapy. It's easily applied, it's non-invasive, and it's a cost-effective method to reduce postoperative nausea and vomiting. Limitations and future research recommendations were found. Each study did not use the same instrument to measure postoperative nausea and vomiting. They all used an analog scale to measure, but some of the scales used 1 to 3, some of the scales were 1 to 5, some of the scales used a 1 to 10 measuring tool. So this lends itself to inconsistencies in measurement of postoperative nausea and vomiting. Also, standard evaluation intervals were not apparent throughout the studies. So in the future, if they used a standardized instrument and a standardized evaluation interval that would measure the effects of aromatherapy at the same time in every study, I feel this would substantiate the evidence. Also, one study by Karaman et al. Conducted a 4-arm placebo-controlled trial, which determined that lavender and ginger were more effective than rose oil in the prevention of postoperative nausea and vomiting. So I think if some studies were focused on finding the most effective scent, that would be important as well. So they could just keep determining the most effective scent, the one scent that would work the best on postoperative nausea and vomiting. I chose lipids theory of change to guide the implementation of this practice project. According to Mitchell, 2013, it correlates well with the components of the nursing process. So you could see on the screen on the left, it has the nursing process and how well it correlates to my 7 steps of the change process model. I feel like the bedside nurses, the biggest stakeholders, will really be able to translate this change process well, since it's so close to the nursing process. So outcome evaluation is important for any evidence-based practice. You want to see if it's actually effective. So postoperative nausea and vomiting leads to extended recovery times, delayed transfers and discharges, which translate to higher healthcare costs. So I would evaluate 3 months prior to the implementation of aromatherapy, and then I would evaluate for at least 3 months after the implementation of aromatherapy. I'd evaluate PACU holding times, same-day surgery holding times. I'd evaluate unplanned admits due to postoperative nausea and vomiting, and then I'd evaluate the perioperative patient satisfaction scores to see if they've improved. I would use the sample t-test to compare the means between the pre and post samples. I would also document everything on a Pareto chart for easy visual analysis and easy dissemination of the stats of my evaluation. I would disseminate the outcome data within my organization in hopes to invoke enthusiasm to continue and sustain the practice change. I do this through holding a perioperative unit huddle. This is attended by anesthesiologists, same-day service PACU and ORRNs, as well as other members of the perioperative team. I would also present this data via PowerPoint presentation to our monthly nursing forum because I'd want the whole organization to know that we are placing evidence-based practices and how well our change is affecting our patient care. And this may inspire others to implement evidence-based practices as well in their units. And that is attended by directors, managers, as well as staff nurses from all over the organization. Optimal dissemination would happen nationally. So I would put in an application for a poster presentation, probably at the American Society of Peri-Anesthesia Nursing Conference. I would also submit an article to the Journal of Peri-Anesthesia Nursing. And again, I want to invoke that enthusiasm nationally so other people are aware of the practice problem and know that there are things we could do to make it better for our patients. So the practice recommendations that I gathered from the literature review are to identify patients who are at high risk for postoperative nausea and vomiting, to use a multimodal approach to treat and prevent postoperative nausea and vomiting, and then to consider ginger, peppermint, or lavender aromatherapy as a holistic adjunctive therapy to prevent or treat postoperative nausea and vomiting. My recommendation is an A, higher level recommendation, which comes from 2 high quality RCTs with consistent evidence. All 6 articles that were reviewed did say that aromatherapy has a positive effect on postoperative nausea and vomiting as well. So to conclude everything we went over, because of my recovery room nursing experience, I wanted to know how effective aromatherapy would be to treat postoperative nausea and vomiting in adults. And I did find that aromatherapy is an effective adjunctive therapy for the treatment of postoperative nausea and vomiting. I would implement this change using Lipid's theory of change. We discussed our outcome evaluations that I would evaluate to see if my change was effective. I discussed how I'm going to disseminate my information both locally and nationally, and I discussed how aromatherapy is safe, cost-effective, alternative, and adjunctive therapy to treat postoperative nausea and vomiting. If you have any questions, feel free to ask.